The current trials right now are only for immunotherapies. So this is a trial that we're about to start here hopefully in the next couple of months using an immunotherapy called pembrolizumab. And the patients will be divided into two groups. Patients either take the drug or they don't, which not taking the drug is the standard of care at this point. So this is a multi-institutional, multinational clinical trial. Another trial called PROSPER, that's a cooperative trial in the U.S. That's using a different drug called nivolumab, and it includes the neoadjuvant portion similar to what I described earlier. It just started just a couple of months ago, so we're barely just beginning to these trials. There are some other trials that are being prepared right now at different ages that I mentioned here. So for the simple messages for adjuvant therapy, it's very important to know at this point there is no approved drug that can be used for adjuvant therapy. So at this point when we see a patient in our clinic, if we resected all their cancer free now, we either lost the patient with repeated imaging or we enroll them in a clinical trial if they would like to do so. At this point there's only one trial that shows benefits in disease-free survival, but not in overall survival. And we certainly need to do deeper analysis of these trials to gain more information. And we definitely would like to encourage our patients to participate in clinical trials whenever they're available. I'd like to acknowledge all our patients who trust us with their lives and take care of them. And without our patients, we wouldn't be here in the center. And also acknowledge my colleagues, members, and collaborators. Without such a lot of this work, would not have been possible. Thank you very much for your attention. Do you have any time for questions, Christopher? Any questions? We can take questions off that in the break. So thank you very much for being here this morning. So I'm going to talk about global surgical resection and the management of advanced kidney cancer. It's kind of strange. There's a saying in Texas, sort of like closing the barn door after the horse is already left. It doesn't make a lot of sense to do surgery in the setting of metastatic disease, but I hope to convince you and show you that there definitely is a role, both for the resection of the primary tumor as well as for potentially resection of metastatic disease. And in fact, arguably, surgery, or the old heal with steel, is better than any chemotherapy that we have to offer. If we were having this meeting 10 years ago, I wouldn't have a whole heck of a lot to talk about. I'd necessarily just slide and go sit down because we really had nothing to offer patients with metastatic disease. Patients who had localized or locally advanced disease were largely treated with nephrectomy, and those patients who presented with metastatic disease usually underwent nephrectomy because we had nothing else to offer you. And then they would get systemic therapy, usually with a immunotherapy that was largely ineffective, and the median survival for patients with metastatic disease was about a year. So it's a new era in the treatment of kidney cancer. There have been somewhere around 12 to 13 new treatments that have been approved for the treatment of kidney cancer in the last 10 years. And so the real question is there still a role for surgical resection of patients who present with metastatic disease in light of all these novel therapies that we have that have prolonged patients' lives? What we do know about these agents is that they are not home runs. They don't cure people. They're patients at best. But we do have plan A, plan B, plan C, and D, and so on. But at the end of the day, patients ultimately become resistant to these therapies, and ultimately they will die of their disease. So what is the proper integration of surgery and systemic therapy in the setting of patients who present with metastatic disease? Well, I'd like to illustrate this conundrum with two cases that really show how difficult it can be to select appropriately for surgical resection of patients who present with metastatic disease. First patient is a 62-year-old white male who presented with blood leukemia. He had some minor medical problems, some minor religious surgery. He had a performance status of 1. So performance status just basically means how active you are with your cancer. So performance status 0 means you have absolutely no symptoms related to your cancer. Performance status 1 is you have some symptoms, but it doesn't affect your daily life. Performance status 2 means you spend less than 50% of your day sitting or lying down as a consequence of your cancer. Performance status 3 means you spend more than 50% of your day lying down or sitting down because of your cancer. Performance status 4 means you're bedridden. And performance status 5 means you're dead. So this patient had a performance status of 1. And you can see on the scan on the right kidney, this locally advanced tumor involving the right kidney. And you can see these little nodules in the lung bilaterally that represent metastatic disease to the chest. So this patient had some anemia, had an elevated LDH, so the blood test that we give sort of give us a measure of overall disease. And the remainder of the labs were normal, and the patient had no other evidence of metastatic disease aside from the nodules that were present in the lungs. So the patient underwent what we call cytoreductive nephrectomy, which means the patient underwent surgery to remove the primary tumor. Here's the pathology. Follow-up scans at 6 weeks showed some modest progression of the pulmonary disease, so basically they couldn't get any therapy for 6 weeks while they were recovering from surgery, and we expect for metastatic disease to grow. So the patient was ultimately started on sunitinib, which is one of the new targeted therapies. They required dose reduction due to toxicity. Ultimately, at 14 months out, I remember what I said before was the median survival was 1 year. This patient already lived 14 months after surgery. They were changed over to everolimus, which is an mTOR inhibitor, and now they're actually over 3 years out and still doing well. In contrast, this is a 73-year-old white female who presented with fatigue and anemia. She also had a performance status of 1, so minor medical comorbidity. And she had basically similar labs to the first gentleman that I presented to you. She still got a locally advanced tumor involving the right kidney and bilateral nodules in the lung that represented metastatic disease. So she underwent a right radical nephrectomy, and at the time of surgery, we actually noted a mass in her right fallopian tube, which turned out to be metastatic kidney. She also has a positive nose, and on final pathology, her tumor demonstrated what we're called subclinical groundbreaking. Basically, that just means a very aggressive form of kidney cancer that wasn't recognized on the imaging that was done prior to surgery. She had 3 out of 10 lymph nodes that were positive, but all of her surgical margins were negative. They removed all disease present in the abdomen. She returned 1 month later with a performance status of 4. Remember, that means she's completely bedridden. She was admitted to the emergency center for failure to thrive. Her labs were all back. Here's a scan. She has massive recurrence in the rest of her peritoneum. Here's a tumor involving her liver, her vena cava. Here's a tumor over here involving the ribs. There's an X for the liver. Again, massive recurrence, despite having negative margins. And ultimately, the patient never got any systemic therapy, no chemotherapy whatsoever. She died of disease 45 days after surgery. Arguably, did not benefit at all from the nephrectomy. So you can see that these 2 patients are exactly the same, yet have 2 very different outcomes. The question is there any way that we can avoid that second scenario? The group from UCLA were one of the first to demonstrate the benefit of surgery, and again, I would argue that back in the day, surgery was offered largely because we didn't have anything else to do. But they noted that those patients who underwent nephrectomy, or even better, nephrectomy followed by immunotherapy, had a significantly better outcome than those patients who were treated with their primary tumor replacement. So this prompted the conduct of 2 randomized trials, one done in the United States, one done over in Europe, where patients were randomized to radical nephrectomy followed by interferon. This was the systemic therapy du jour versus interferon alone. And both the European trials shown here, as well as the United States trials shown here, demonstrated that patients who underwent cytoreductive nephrectomy had a doubling of their survival relative to patients who were treated with their primary tumor replacement. So it suggested that somehow, some way, this primary tumor was influencing the overall behavior of their disease, and by removing it, patients could have a better outcome. Well, the group from UCLA noted that interferon is largely thought to be a rather effective therapy. Patients feel like they have the flu all the time. The response rate is only about 5%. And so they said, well, you could offer patients a better therapy in their minds at the time, which we consider was better therapy. Surgery followed by better therapy would result in better outcomes for patients. And in fact, they plugged in their retrospective database, they plugged in the entry criteria for the SWOT trial, the trial done in the United States. And they noted that patients who received IL-2, arguably a better therapy, did better following the nephrectomy. Well, as I said at the start of this talk, we now have 13 better therapies. So surgery followed by all these different better therapies should really result in better outcomes for patients. What's interesting, though, is we're not practicing what we preach. Take a look at this slide. This shows the utilization of cytoreductive nephrectomy in the United States over time. The new targeted agents were introduced in 2005, 2006. And you can see right at that time, cytoreductive nephrectomy was on the decline. So while we believe that the research shows us that surgery followed by better systemic therapy would result in better outcomes, it would appear that in the research community, people don't believe that. They think that systemic therapy alone is the best option for patients. And that's also shown in this Mayo Clinic study, where you can see the blue bars on the top graph decline over time, showing the decreased utilization of cytoreductive nephrectomy in the era of targeted therapy. Well, why would you not want to do cytoreductive nephrectomy? Well, I can tell you that having immunologic phenomenon where somehow surgery exposes new antigens or removes some sort of immunologic sink. There have been hypotheses that perhaps it alters the metabolic milieu and that's somehow anti-tumoral. Or perhaps it's some sort of endocrine or paracrine phenomenon where we're removing a tumor that is secreting growth factors that ultimately cause disease progression. Well, there are data that indirectly give us some hints as to how cytoreductive surgery works. We did this study, a retrospective study, looking at patients with non-clear cell versus clear cell histology. And what we noted was, in the setting of non-clear cell histology, cytoreductive surgery really did not demonstrate a benefit. So from my perspective, that tells me that just removing tumor is not the answer. There's got to be more to it than that, otherwise we would have seen a benefit in non-clear cell histology. And these are some intriguing data out of that SWOG study that I showed you, the randomized trial looking at nephrectomy followed by interferon versus interferon alone. And what they looked at was the patient's post-operative creatinine, which is a measure of kidney function. And they categorized patients as anyone who had a change in their creatinine, an increase in their creatinine, which would be translated into a decline in renal function and compared them to patients that did not. And they noted that the patients who had a decline in their serum, an increase in their serum creatinine had a significantly better survival relative to patients that did not, suggested that perhaps this relative azotemia or relative renal insufficiency was somehow intratumoral. So back in the day, we used to see patients, and we look at their tumors under the microscope, we would see these tremendous lymphocytic infiltrates where their immune system was infiltrating the tumor and say, wow, this guy's going to do really well. His immune system is killing this tumor. And in fact, we were exactly wrong. So those patients as shown here who had marked lymphocytic infiltrates did the worst relative to those who did not. And now, with further research, we know why that is. Because the tumor cells were actually turning off the immune system as the tumor attacked it. We now know that the tumor expresses molecules that interact with the immune system and can shut them down. And actually that is the basis for the novel new immune checkpoint blockade inhibitors that we're using in the clinic, where we can block that interaction and no longer allow the tumor to shut down the immune system. Is there any clinical evidence for systemic influence of the primary tumor such that removing it would remove that influence? Well, kidney cancer is famous for paraneoplastic syndromes, where patients present with a whole host of different symptoms that are completely unrelated to their primary tumor, but are related to growth factors that are secreted by the tumor. We've all heard of spontaneous progression of metastatic disease, which I've seen twice in my career. Reportedly, it happens 1 to 2% of cases, and it's only associated with clear cell histology. And as I showed you in my second case, explosive progression of metastatic disease can also follow surgery. Thankfully, it's rare, but when it happens, it's memorable. So is there any role for cytoreductive surgery in the setting of targeted therapies, these new targeted therapies that we have? Well, there currently are 2 randomized trials trying to answer that question. This is a trial called the Carmina trial, which currently is ongoing in France, where patients are randomized to nephrectomy followed by sunitinib versus sunitinib alone. This trial has been going on for 10 years. They still haven't reached their accrual goals. And in large part, I think it relates to the fact that most people believe that cytoreductive surgery does still play a role, and so patients are unlikely or unwilling to be randomized. And arguably, when this trial finally does read out, the question is, will it even be relevant? Will we even be using sunitinib to treat patients with metastatic kidney cancer? Because it's going to be probably another 5 to 7 years before this trial actually reads out if it ever does. So another trial that's ongoing, or was ongoing, is this trial looking at the timing of surgery in the setting of systemic therapy. So basically, patients were randomized to upfront surgery followed by sunitinib versus 2 cycles of sunitinib followed by surgery followed by continued sunitinib. So it doesn't ask the question, should we do surgery? It asks the question, when should we do surgery? So again, the problem with this trial is that it closed because no one was entering patients. So, in the setting of targeted therapy, we have no level 1 evidence to suggest that surgery plays a role. The problem is, I clinic Wednesday. I can't wait for these trials. I have patients that are going to show up with metastatic disease. What do I tell them? Do I tell them that there is no role, that we don't know what the role is? Do I enter them in a clinical trial? How do I manage them? Well, there is retrospective data that gives us some clue as to whether or not surgery does play a role in the setting of targeted therapy, in the setting of metastatic disease. These are data from the expanded access trial that was conducted by Pfizer when sunitinib was being developed. And they looked at patients who had prior nephrectomy, not necessarily cytoreductive nephrectomy, but had their kidney removed at some point in the past, and compared them to patients who were treated with their primary tumor in place. And you can see that there was a doubling in the response rate for patients who had had a prior nephrectomy. And those patients who had a prior nephrectomy had an improved progression-free survival and an improved overall survival relative to patients who were treated with their primary tumor in place. The survival was almost double. Admittedly retrospective, admittedly biased, but does give us some indication that controlling the primary tumor does play a role in the management of these patients. These are data from the Dana-Farber Institute, where they looked at patients who presented with metastatic disease with their primary tumor in place, and they noted again a doubling in the survival for patients who underwent cytoreductive surgery prior to systemic therapy. Now again, the reason why these patients in the no group didn't have surgery is suspect. They were probably poor surgical candidates, they probably had advanced disease, but it still gives us some indication that controlling the primary tumor is important in the setting of metastatic disease. And this is data that we published more recently looking at the SEER database, which is a large national collection of patient data. And we noted again that those patients who had cytoreductive surgery had a significantly better outcome in the setting of, or the era of targeted therapy, although the SEER database doesn't actually tell you what specific therapies those patients received. That's not to say that everyone should have cytoreductive surgery. As I showed you in that second case that I presented, I made the wrong decision. Surgery is different. More recently, we looked here at MD Anderson at 566 patients who were treated with cytoreductive surgery between 1991 and 2007. And we compared them to a group of patients who received only systemic therapy alone with their primary tumor in place. So we compared outcomes. Now, the bent here at MD Anderson is to treat patients with surgery if at all possible. So you can imagine that the patients that we did not treat with surgery were the worst of the worst. And in our hands, the worst of the worst survived 8.5 months. So we went back to our surgery group and we said, okay, if we did surgery on you, you did not at least survive 8.5 months, then we probably didn't help you with surgery. And then we asked the question, what clinical factors can we use to predict your survival after surgery? And what we noted was that those patients who presented with a low serum albumin, an elevated LDH, the presence of liver metastases, symptoms that were related to metastatic disease, such as bone pain, cough related to pulmonary metastasis, and so forth, and nodal involvement, meaning involvement of the lymph nodes by cancer, either in the chest or in the abdomen, and a locally advanced disease stage, all of these factors were associated with an adverse outcome. And what we noted was in our study that if you had 3 factors or less, your outcome was better than the people that received only systemic therapy. But if you had more than 3 of these factors, your outcome was the same or even worse than the patients who received systemic therapy alone. And so now prospectively, we use these criteria to better help us select patients for surgery and help us avoid the consequences associated with that second case that I showed you. This is another study out of Canada where they looked again at factors that predicted for outcome in patients who underwent cytoreductive after surgery and came up with some very similar findings. The presence of anemia, elevated calcium levels, elevated white blood cell levels, elevated platelet levels, poor performance status, and a diagnosis to treatment time of less than 1 year, meaning that you presented and got treatment in less than 1 year from your presentation. All of these were associated with outcome. So with regards to cytoreductive nephrectomy, cytoreductive surgery does improve survival in properly selected patients. The goal of surgery should be to remove the majority of tumor burden with one surgical procedure. Poor performance status, the presence of liver, brain, or bone mets, the presence of nodal metastases, and the presence of sarcomatoid histology all predict a poor outcome. And in that situation, those patients are probably best served by receiving upfront systemic therapy, followed by possibly delayed surgery if they respond. So I want to talk just a very little bit about surgical resection of metastatic disease. So this is not resection of the kidney, but resection of metastases, be they brain mets, bone mets, lung mets, what have you. So a little bit about the epidemiology of metastatic kidney cancer. 63 to 65,000 patients are diagnosed yearly. Of those, 30% present with metastatic disease. And even those patients who present with localized or locally advanced disease, 30 to 40% of them are destined to ultimately get metastatic disease. So you can see that metastatic kidney cancer is a real health problem. 13,000 patients per year die of metastatic kidney cancer. And the rate of kidney cancer is increasing by 2% per year. What are the challenges associated with the management of metastatic disease? It is not responsive to most chemotherapies. In fact, radiation is only used for palliation of pain. The minority of patients respond to cytokine therapy, which is interferon, interleukin-2, the old systemic therapies. Even with the new targeted therapies, complete responses are rare. These agents do not cure. They control, but they don't cure. And I would argue that surgical therapy, when possible, represents the best form of treatment and is better than any chemotherapy that my medical oncology colleagues have to offer. Steel to steel, as they say, is certainly the best option for patients with metastatic disease once appropriately applied. So just a couple studies that have looked at this, and the biggest problem with these studies that you have to take with a grain of salt is that they're all retrospective, meaning that we look back at our experience as opposed to taking patients prospectively as they walk in the door and randomizing to surgery versus no surgery, which probably can never be done. There's just not enough patients to actually complete a trial like that. So in large part, patients who underwent surgery, there's a selection bias. They underwent surgery because they had favorable disease, probably had good performance status, were very eager to proceed with surgery, and so all of those things could impact the outcome. So there are numerous studies retrospectively published in the literature, but the outcomes are really impressive. Here's one from Sloan Kettering, where patients who underwent a complete metastasectomy, the 5-year overall survival rate was 44%. Almost half of the patients were alive 5 years after surgery, which is unheard of in the setting of metastatic disease, particularly in that era. Here's another study again out of Sloan Kettering, where any patient who had any metastasectomy, the 5-year overall survival rate was almost 50%. This is a study out of the Mayo Clinic where they looked at over 1,000 patients. Any patient who had a metastasectomy, 5-year overall survival, 44%. Very impressive. And again, another study out of the Mayo Clinic where those patients who could undergo complete metastasectomy, their 5-year cancer-specific survival, so that's not even overall survival, means being disease-free, 5 years out from the surgery, 45%. So in highly selected patients where aggressive surgical resection can be accomplished, the outcomes can be excellent. So just to delve into a few more of the details, this was a study out of Sloan Kettering, 278 patients. 57% of patients had lung metastases, 19% had bone. Complete resection was accomplished at 59%, incomplete at 41%. And patients who had a complete metastasectomy, the 5-year overall survival rate was 44%. And this is from the Mayo Clinic, 727 patients. Again, you can see the distribution of metastases. They were able to accomplish a complete resection at 26%. The 5-year overall survival in the cohort was 15%. This is a more recent study out of Sloan Kettering. 129 patients, you can see the distribution of lung and bone metastases. They were able to get a complete resection at 31%. The knowing was performed at 66%. And when they compared the two, the 5-year overall survival for the group that had any surgery for metastatic disease was 49%, with a median survival of 45 months. This is a study of more than 1,300 patients with a variety of different metastatic deposits. They did not report whether or not the patients had a complete versus incomplete resection. But they did note that any patient who had any metastasectomy, their 5-year overall survival was 44% and the median survival was 44 months, which is quite impressive relative to the group that did not undergo metastasectomy, where their survival was only 22 months. And then lastly, this is a more recent study out of the Mayo Clinic, 887 patients. Complete metastasectomy was accomplished in 14% of the patients. They looked at timing, location, number of metastatic sites, and performance status relative to outcome, as shown graphically. So those patients who had a complete surgical resection, the median survival was 4.8 years versus those without complete resection, the median survival was only 1.3 years, shown graphically here. And patients who only have lung metastasis